anticoagulation on horizon, Betrixaban, Tecafarin, and others, first of all, I have nothing to declare. So we're going to talk about some historical perspective and what's the ideal oral anticoagulation and the current under development drugs and the discontinued one. So on 1958, the Patient magazine gave this news about the Coumadin, the amazing pill that keep President Eisenhower alive. They mean the warfarin, which started in clinical use on 1950, and then on 2010, the oral novel oral anticoagulation start to appear. As all of us know, major limitation of vitamin K antagonist was the slow onset and offset of action, the narrow therapeutic index, and the variable and unpredictable anticoagulation effect due to genetic polymorphism of cytochrome P2C9 and multiple food and drug interactions. That's why only half of eligible patients receive vitamin K therapy, and of those, the INR is out of the recommended therapeutic range for around 30 to 50% of time. The ideal anticoagulant supposed to be on oral route, preferably once daily dose, and rapid onset and offset, and predictable pharmacokinetic and pharmacodynamic, and less food and drug interactions with fixed doses and wide therapeutic window, and easy to use with no need for monitoring. This is the coagulation cascade and the mechanism of action of anticoagulant. We have the intrinsic pathway, and we have the extrinsic pathway, and the common pathway around which the anti-factor 10, rivaroxaban, apixaban, and Betrixaban, and Betrixaban was worked, and the antithrombin inhibitor, like dabigatran, work on inhibition of thrombin, so they prevent the clot formation. The currently underdeveloped drugs, oral anticoagulation, included some anti-factor X like Betrixaban and others, and the new novel vitamin K antagonist, the Tecarfarin. We will go to discuss some points about and some landmark clinical trials. So the Betrixaban is a new direct factor 10 inhibitor with a half-life of around 24 hours with minimal renal and hepatic metabolism, with maximum concentration reached around 3 to 4 hours after administration. 60% of this drug will protein bound, and the initial approved dose is 160 milligram daily, followed by 80 milligram daily to be taken at the same time of the day with food. 3 trials studied this drug, 2 phase 2 trials, and other one is phase 3 trials. Those trials, the expert and APEX trial, studied the efficacy and safety for thromboprophylaxis in patients at risk of venous thromboembolism, while the Explore XA trial was studied against for stroke prevention in AF, and the FDA approved this drug on June 23, 2017 for venous thromboembolism prophylaxis. If we compare the Betrixaban to currently available under clinical use, NOACs, so we found his plasma peak was around 3 to 4 hours, and his plasma trough will be around 24 hours without any nothing to monitor. The APEX study design included a 2 arm, basically 3 arms, 3 stages. It is a double-blind, double-dummy trial, included a 7,500 patients. In the first stage of this trial, around 2 weeks, they compared the Betrixaban 80 mg with a loading dose of 160 mg compared to enoxaparin subcutaneous 40 mg daily. And then the second stage included Betrixaban 80 mg versus placebo for around 42 days. And the patient, this is almost on discharge from the hospital, and the patient will came for evaluation and ultrasound at day 35 plus minus 1 week, and then follow-up visit, safety visit at day 30 days after the first visit. And the primary efficacy endpoint of this trial was the composite asymptomatic or symptomatic DVT and non-fatal pulmonary embolism and venous thromboembolism-related death. The primary safety endpoint was the measured bleeding through the 7 days after administration, and they found the symptomatic venous thromboembolism in all patients randomized. As it's clearly, you can see here, the composite of symptomatic proximal or distal DVT in enoxaparin arm around 1.8, and as the time go, here at around day 40, it's around 1.4. At the time going, the risk is increasing. It reached around 1.8, and it's clearly here. It's a much lesser in the Betrixaban arm. At the day 40, it's around 0.9, and then 1 with a significant p-value. Regarding the stroke and TIA, there is a trend with a better efficacy in prevention of stroke with Betrixaban arm. The primary safety endpoint included the major bleeding, almost comparable in between both arms. However, regarding the major or clinically relevant non-major bleeding, there is a significant trend toward increasing risk with Betrixaban arm. Regarding the fetal bleeding, there is similarities in between two arms. However, regarding the intracranial hemorrhage, the enoxaparin arm is much higher regarding the rate of incidence of intracranial hemorrhage. So the big key message: among hospitalized patients, medically ill, extended duration Betrixaban associated with around 30% reduction in fatal or irreversible ischemic or bleeding event compared with standard duration enoxaparin followed by placebo. So who do you offer extended prophylaxis? The proposed use criteria basically included those patients admitted with heart failure, respiratory failure, acute infection, acute rheumatic disorder, acute ischemic stroke, plus minus additional risk factor like the age or thrombophilia or a chronic heart failure. Regarding the Explore XA trial, the Betrixaban compared with warfarin in patients with atrial fibrillation risk. It's a phase 2 trial, randomized trial, dose ranking study. So this study enrolled the 508 patients with at least one stroke risk, with Betrixaban dosage ranging from 40 to 60 or 80 mg OD versus warfarin INR2 to 3 with TTR of around 76.4. They found the primary endpoint was the major or clinically relevant bleeding. The Betrixaban 40 mg dose shows lower than warfarin bleeding. However, the 60 and 80 milligram OD was comparable to warfarin in the primary safety endpoint. So in conclusion, in this trial, Betrixaban at a dosage of 40 to 80 mg per day was well tolerated in AF patient at risk for stroke, with a risk of bleeding was similar to or lower than warfarin, that of well-managed, TTR in the therapeutic range. A larger and definitive phase 3 trial of Betrixaban is indicated. The second drug was the Betrixaban It's another direct factor 10 inhibitor with low molecular weight. Single oral dose of 60 mg Betrixaban is immediately absorbed with a plasma protein binding between 60 to 85, and the peak after 0.75 hours, the half-life between 11 and 14, the metabolism of drug is half renal and half hepatic. Several clinical trials have been completed on the use of Betrixaban for the prevention of management of venous thromboembolism. Significant inverse relationship was noted between Betrixaban dosage and venous thromboembolism incidence with a significant p-value. The bleeding rate was similar to enoxaparin, and no dosage exhibited superior efficacy than enoxaparin. What about the third one? Betrixaban is a low molecular weight direct factor 10 inhibitor. The peak concentration is usually reached between 3 and 4 hours with a half-life of approximately 10 hours. 16 to 35% of drug is excreted through urine. And earlier studies showed that this drug was effective to inhibit arterial thrombosis with effect comparable to aspirin plus clopidogrel. Phase 2 adaptive dose ranging study comparing the assessment of 100-fold dose range Betrixaban administered in around 1,411 patients undergone total knee replacement. Betrixaban was equivalent to enoxaparin 30 mg BID for prevention of venous thromboembolism and comparable bleeding risk. Before the last one, the Betrixaban drug, the first multicenter dose finding study was published in 2010 and enrolled around 1,038 patients undergoing elective total knee replacement. The study had 3 arms, compared Betrixaban to 30 mg subcutaneous enoxaparin. The 10 and 20 mg BID dosage of Betrixaban was stopped early because of considerable high thrombotic events. However, the 40, 60, or 80 BID or OD dosage shows dose-dependent decrease in venous thromboembolism episode and all-cause mortality in comparison to enoxaparin. So they concluded that the rate of secondary efficacy outcome, DVT, or symptomatic venous thromboembolism, the major and clinically relevant non-major bleeding, and or the adverse event was similar to patient using the enoxaparin, with the bleeding risk was not influenced by the Betrixaban dose. The last one in anti-factor 10 inhibitor was the Noxaban, which is with a structural similarity to the rivaroxaban, absorbed faster than rivaroxaban, with a faster plasma peak around less than 1 hour, a very fast decline between 3 and 9 hours. A simulation experiments revealed that approximately 20 mg and approximately 40 mg of Noxaban will be comparable to 10 and 20 mg of rivaroxaban respectively. Okay, the last drug is the Tecarfarin, which is the structural analog of warfarin. It's metabolized through the esterase pathway, so it's avoiding the cytochrome B450 mediated drug-drug interactions and avoiding drug-food interactions. There's genetic variation of cytochrome B450 enzyme system. In open label phase 2A study of 66 AF patients with a SHAT-FAST score of 0 to 2, Tecarfarin treatment was associated with a mean TTR of 71.4% after initial 3 weeks of dose titration. It acts like the warfarin, again, inhibition of vitamin K dependent clotting factors. Tecarfarin elimination half-life range from 86 to 140 hours with no dose dependence, it have relatively high bioavailability. To maintain an INR of 1.7 to 2, you need 10 to 20 mg of tecarfarin. Tecarfarin may become a superior alternative to warfarin. The landmark trial, MedicReS trial, it's a randomized double-blind comparison of tecarfarin against warfarin. It's a phase 2 to 3 randomized and blinded trial. It's designed to compare the quality of tecafarin versus warfarin as determined by TTR. They enrolled 607 patients. It demonstrates no difference between tecarfarin and warfarin in composite clinical efficacy endpoint, bleeding, and thrombotic events. At least around 3 trials was done to study the pharmacokinetic and pharmacodynamic of tecarfarin, included the tecarfarin single ascending dose study and tecarfarin multiple ascending dose study and tecarfarin warfarin comparison study. The INR and tecarfarin dose response relationship for cohort with a starting dose of 10 up to 40, you can clearly see here to achieve targeted INR around 2.1, you need at least 10 days. You can achieve this to 2.1, and the 40 mg dose is the fastest one can achieve that. So it might be the dose dependent. Okay, what regarding a lot of oral anticoagulation previously was studied, but it discontinued, like the zemilagatran and Betrixaban and others, because they showed whether a lot of side effects, especially the liver toxicity. So the challenge in clinical adaptation of new anticoagulation still a lot, included no validated test and no establishment therapeutic range, no antidote available, and difficult assessment of compliance with the potential for unknown long-term adverse effect, and balancing cost against efficacy, and lack of head-to-head studies comparing these new agents. So in conclusion, among hospitalized medically ill patients, extended duration of Betrixaban associated with around 30% reduction in fatal or irreversible ischemic or bleeding event compared with enoxaparin, and a large phase 3 trial for Betrixaban in stroke prevention in AF is needed. A definitive trial of Tecarfarin versus warfarin in patients requiring chronic oral anticoagulation is safe and feasible. Tecarfarin may become a superior to vitamin K antagonist alternative to warfarin. And thank you very much.
Thank you, Dr. Noman, for impressive presentation, for your impressive presentation. My question is, can we start using Betrixaban soon for stroke prevention in AF with high CHA2DS2? Thank you.
Thank you, Riza. This is a really interesting and very important question. And all of us actually waited for this. Basically, as we mentioned in the presentation, Betrixaban is approved by FDA for for DVT and venous thromboembolic prophylaxis, especially for extended duration for high-risk patients, as we mentioned. And it got an superiority to enoxaparin, and even though more safety. But regarding the stroke prevention in AF, basically, we have a study, as we mentioned before, but the study, which is Explore study, as I show before. So this study, they take a less number of patients, and they show that it will be promising. And I think, as we mentioned here in our conclusion, we still need a large phase 3 study in stroke prevention on AF. We still need a large study for stroke prevention in AF, to make sure it is as effective as the NOAC and or warfarin and less also bleeding risk. Hope I answer your question.
Thank you, doctor, for answering.
Thanks, Riza.
Thank you for nice presentation, Dr. Noman. I have one question.
Thanks.
What is the major difference between Tecarfarin and Bulfarin?
Oh, thank you very much for this question, Sina. The Tecarfarin is a novel vitamin K antagonist, and it will be basically it is a structural analog of warfarin. So this means it's acts his mechanism of action almost as warfarin. It's act on the same coagulation factor. So this is the basic mechanism of action. But the major difference, as you said, what makes it superior to warfarin, doctor, if it is similar to warfarin? So the major points is the metabolic pathway. So it's avoidance of cytochrome P450 pathway. As we know, this pathway is complex pathway, and a lot of drugs can interfere with it. So this one can make a lot of drug-drug interaction and food-drug interaction, and can make the patient either less efficacy or less INR, or expose him to bleeding risk. So it is metabolism across stress pathway, make him more safer and less drug-drug and food-drug interaction. I think this is the major thing which make us focus on it as a promising drug in the future, which will make a stable INR, and the TTR will be much stable and most of the time in the therapeutic range. Thank you very much for this question.
Thank you for answer.
Thank you very much.